Good evening, everyone, and welcome. I am Lauren Gates, and I am thrilled to have you along with my co-hosts and panelists this evening for our free masterclass. And it's titled Pediatric Airway Health, Dawn of the Primary Care Dentist. And we just love this title, and we are thrilled to be with you tonight because it is February's National Dental Health Month. And what better way to spend it than to really focus on airway health and all the great work that our primary care dentists are doing to guiding these little ones to health. So we're really thrilled to have this class tonight. It's going to be a combination of a panelist discussion. We will take a little bit of Q&A if there's time for it, but we're really, really excited to feature three of our AHS alumni who have taken our coursework and literally ran with it. So I'm pleased to introduce Dr. Jenna Schwibner and Dr. Cassie Klein. Dr. George Rivera will be joining us, and they're just like general dentists, just like you, who just they listened to a course and then they got the bug and they went on fire and changed the world. So we're really, really excited to feature them this evening. I'm thrilled to have our panelists here because without them, we wouldn't have airway education as we know it, and we wouldn't have primary care dentists because this isn't taught in schools yet. So I'm thrilled to introduce everyone. We have Dr. Susan Maples, we have Dr. Steve Karstensen, Dr. Ben Moralia, Dr. Kevin Boyd. And why don't we just go along the horn really quickly and just do a quick introduction before I do some of the housekeeping items, just so everyone can kind of get a feel for you, who you are, where you are, and how you got involved in airway. So why don't we start with you, Dr. Maples? Susan, I know you like to be called Susan.
So I'm introducing myself. Nice.
Yeah, please.
I've been in private practice this is my 40th year. I didn't really start total health dentistry until about 25 years ago, but I've been working with children in a unique way, trying to help put them in the driver's seat for a preferred future, even out of the most dire circumstances in their family. So lifestyle related stuff led me to adult total health. And when I started looking at all the airway problems we have in adults, it was a calling, a literal heart calling to back up and start to look at how we can predict and preempt this in children and save these kids from ever falling into the rut that we see with adults. So I'm thrilled to be here. I'm a really big fan of yours, Lauren, and of what you're doing and of all of these panelists. So thank you for the honor.
Thank you. And check out her book, Brave Parent, because every parent should get that book. It's so empowering, and it'll take the patient education off your shoulders. It'll just reinforce all the messages. So thank you. Let's go with Dr. Steve Karstensen. Give us a quick overview.
Hello, everybody. I'm in my 42nd year in dental practice now, Susan, so I just got you by a couple of years. And the last 28, I've been treating adults for airway problems. But in 2018, I started the ADA Children's Airway Initiative by holding a conference with a round table with all the leaders in children's airway. And we realized what a big problem we have. And so I'm very, very happy to see all of the effort that's being expanded on that direction to bring the awareness to what we can do for kids. And that way they don't have to grow. I don't want to grow any more patients that would end up in a practice like mine, 20, 30, 40 years from now.
Thank you so much. Dr. Moralia?
Yeah, good evening, everybody. I'm really honored to be with the panel. I'm 31 years in dentistry. I can't believe it myself. And it's been the last 2 decades. I pivoted 2 decades ago to get away from fixing the teeth. I did that for 10 years. And then I decided to change course. And basically, it's been 2 decades of growth and development. Even though I do treat in all the age groups, just like with Susan and Steve, I would much rather prefer all of the kids get attention so that no one has to treat the older age group. It's not that fun treating older, and some of the damage is already done. So yeah, if we could get the kids moving along in the right direction earlier, that's great. I can't wait to see what Jenna and George and Cassie have to share, because
yes,
I think I'm to blame for some of it.
Right.
I don't know if they want to thank me or blame me, but I'll take either way. It's totally fine. But I'm really excited to see what they've got to show tonight.
Thank you. Dr. Boyd, welcome.
Yeah,
You're muted.
Oh, here.
Oh, I heard him through your.
Yeah. Okay.
There you go.
Yeah, I'm going to enter my 40th year in dentistry next year, but Steve and Susan didn't tell you, but if anyone knows the story of Doogie Howser, both of them graduated high school when they were 10. So they got into dental school a lot younger. So that's why they've been in it longer than me. Um, anyway, I've been in pediatric dentist since 1988. I went to Iowa. And that's when they taught us to do early aggressive orthodontic treatment. That means before the age of 10, which, as many of you heard me say, that's a geriatric patient to me now. And, Ben has taught me that the upper jaw is the criminal, the lower jaw is the victim. These things don't self-correct, and we got to get in early. So that's the influence I'd like to have on this whole wonderful dream team that Lauren, you've assembled here.
Well, I also have to give kudos because you coined the term primary care dentist. Do you want to talk about that a minute? Because I based this whole theme on that because I love that term, and I know Dr. Carstensen, you adapted that in your messaging, so it is sticking a little bit. So why don't you tell us how you came up with that, and then we'll go over to our panelists as well.
It started in casual conversation, probably over a beer or listening to some blues or jazz with Steve. And Steve liked it. And Steve said, Kev, I'm going to try to get this to a higher level, and ran it by some of his colleagues at the ADA. And it's starting to appear in writing in different places. And if there's, a pediatrician's a PCP, right? So why not primary care dentist, PCD? And who's going to save the world? It's not going to be specialists. Is it, pediatric dentists are too busy putting out fires, and orthodontists are too busy straightening teenagers' teeth. It's going to be the primary care dentists like Ben and Susan and Steve and Jenna, so many other people that really, they're the ones who are doing this. They're the bread and butter. So I'm glad. PCD, general dentist, primary care dentist.
You say that pediatric dentists can be PCDs as well. We don't want to leave anyone out because they're the first line in many of these cases, correct? Because you tell pediatric dentists that they're PCDs as well. So you want to just elaborate on that?
Picture here. Yep, I know. I forgot to say George too.
Okay, yeah.
Sorry about that, Karen. Yep.
Okay. Is George with us yet? Not yet. He's having trouble logging on, but Dr. Dennis Swibner, welcome. I'm so thrilled to have you on here, and it seems like it's a long time coming because your journey has just been so fun to watch. Just from taking your first course with us, then I did your team training, and here you are. And tell us a little bit about your journey. And I can't wait to see your case and your story, but just a little overview before we get into your 15-minute presentation.
Sure. So yes, Dr. Ben is to blame. It was not too long ago. I think it was 2019 when I first got exposed to Dr. Ben at a little sampling course. And once I heard what he had to say, as a mom, I was pregnant with my third, who's now almost 6. And I knew that at least for my children, I needed to do better. And what turned into trying to find work-life balance as a mom of practicing for almost 10 years at that point and thinking I wanted to slow down and maybe work part-time and all that, that really did kind of flip my life upside down because I've forever need to help as many kids as possible now. Once you start helping a few and you help your a couple of friends, a couple of family members, you quickly forget how to say no. And every kid, if they go a night without breathing properly, that's a night too long. So I do come from a practice that was mainly a retirement community. So older, 65 and older was kind of my average patient. And so I do have a lot of those patients that I need to treat, that are already sleep apnea, wearing CPAPs, maybe oral appliances. I do treat some of the adults as well. but definitely the most rewarding thing to do is to catch the kids early. So now it's my waiting room, my schedule has completely changed. There's kids everywhere. There's kids flying from different states in, just because there's not enough of people doing this. So just like Dr. Ben, I'm quickly realizing that my hands can only do so much. So one of my passions is spreading the word, and that's why I'm super excited to be here as part of this panel, because we need to get more doctors doing this, and we need to not burn out the fabulous practitioners like the ones we have here that are doing it, because we can't do it alone. So I'm so excited to be part of this. The movement and the advancements that has taken forth in the last 5 years has been incredible to watch. And I just feel so blessed to be part of it. And I can't thank Dr. Ben enough for inspiring me to become what I am today.
Thank you. And Dr. Klein, oh my goodness, you're on fire too. I think that how many children have you treated? I mean, do you have a number or an estimate?
I would have, in hundreds and hundreds of kids. And what's funny, when I started my practice, I said, I don't want to treat children. I just want adults. It's easy. That's what I know. And I even remember telling my construction people, I was like, don't put any kids' toys out there. I don't want, and now I think 80% of my practice is probably kids.
Right.
Yeah.
Yeah. So tell us about the change. How did that happen? How did that come to pass?
Yeah, so I had just kind of started hearing about airway stuff, kind of the buzzword. Around that time, my mom had a heart attack, and it turned out to be undiagnosed severe OSA. And so I got very curious. I started asking questions, and then I started treating a lot of adults. And then as you go, you realize you can get to these problems earlier and earlier and earlier, and just prevent a lot of the things that I was treating for a long time. And so that's kind of how it evolved. And the magic is in these kids, and treating them early and getting a head start on it just sets them up for such success, and truly a passion. And I'm like so happy to be here and to be part of all this. It's wonderful. And again, Dr. Ben to blame for sure.
Well, thank you. Thank you all. I know we're going to just have George come in, Dr. George Rivera, when he can. So I just wanted to welcome everyone here on this call, and thank you for your passion on a Wednesday night joining us. There's other things you could be doing, and you're just as passionate and just as curious, perhaps. So we're thrilled to be here to help you learn more, explore more, or maybe just reinforce what you're already doing and saying you're not alone, and there's other people out here doing that. But let's see who we have with us tonight. Let's take a poll. I always like to see who's in the audience. So we'll go ahead and put up a poll and welcome everyone. Okay, we'll give it a minute. And I apologize if your field isn't listed. If it's not listed, you can put it in the Q&A session. All right, we're almost there. 100% answer. All right, well, here we go. We have a nice result today. So a nice mix. Dentist wins this one. So hopefully we'll get a lot of new interested airway dentists, because as it's needed, there's certainly not a shortage of children who would benefit from this. So thank you, everyone. We'd like to welcome you to this evening. We are also thrilled to offer a raffle at the end for a free airway, a foundational airway health course with Dr. Ben Morales. So that'll be raffled at the end. And we also have a couple of surprise flash sales just for our live attendees, and they're deep savings. So stay to the end for that. And then I'm just going to give my boring a little statement here just to clear us for any type of legalities. The following presentation is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. Okay, and just in time, we have George. Let's see if he's Oh, I thought he was coming on, but he's figuring it out. So we will wait for George for his introduction, because he is also really inspiring what he's doing. But let's just kind of have a little discussion here amongst ourselves, amongst this panel, about kind of when this really took off, of being airway and an airway advocate, if you would. And Dr. Carstensen, let's talk about that ADA, the 2017 call to action. And, you know, from back then to where we are today, do you see any strides, and what is the future of that call to action?
Yeah, in 2017, what do we got here?
You're
Kevin,
good.
we got okay. In 2017, Kevin and I are in the same room, so we got to.
Okay, that's trouble.
We'll be listening for that. So in 2017, the culmination of a 2-year process, the American Dental Association formed their first policy statement that had something to do with dentistry and medicine working together. And in that document, which mostly was about dentist screening for sleep-related breathing disorders, working with their medical colleagues to make sure that something good was going to happen to this, and then how to cooperate with that. One of the paragraphs laid it clearly on our shoulders to notice when children weren't breathing well, and then using a referral or treatment to address those issues that are found. And it was specified in there about growth and development and function, then to help the child create a optimal physiologic breathing pattern. So that was a powerful statement, but there's no definition for that. And there wasn't any guidelines for what to do to implement that. And so that's what started the process of the ADA Children's Airway Initiative in 2018. And the people that came to that meeting are some of the seated the leaders of today. Many people that were at that first meeting, and now this year we'll be in our 8th edition of that meeting. The people that were there went back to their communities, and just like Cassie discovered in other stories here, it was so powerful to be able to see these things in children and then figure it out. And back in 2017, 2018, there wasn't a lot of airway awareness for little kids. I mean, there was orthodontic awareness for expansion, and certainly there were some people that were doing some good things. And so the efforts, the passion, the thoughts fell on fertile ground in many places. But it also inspired people to go seek Ben Morale and have him change their lives, because it was so powerful to be able to go to those families and finally offer something different than what they've heard before, finally offer a new perspective, finally see something that nobody had seen before, and allow a treatment to take root in pediatric and orthodontic practices that would actually make a difference in kids' lives. I mean, not that anything that pediatric or orthodontists did was, useless. Nothing like that. It was just, this is all a yes and. So taking what we were able to do before and then adding into it an awareness of breathing. And it's grown and grown and grown since then. I'm so encouraged when I see Airway Health Solutions start up, and I see groups that are focusing on kids' airway, and I talk to pediatric dentists or orthodontists that see little ones, and they thought, well, yeah, of course we're going to talk about airway, and we don't stop anymore at just the teeth. Now I'm seeing it grow and grow. It's not grown enough yet, but that's what we do these kind of things for. So
wonderful. And Susan, you've been doing this for quite some time too. You did this way before 2017, the call to action. How did you get started, and why, before it was a thing of I don't even want to say popularity now, because we're not quite mainstream yet.
I wish it was popular. As so many of you know my personal story, I grew up very sick as a child with 2 parents who smoked 2 packs a day each, struggling for my life, hospitalized 7 times for pneumonia under the age of 12. And I know what it's like not to be able to breathe. And it was really just hurting my soul seeing these kids. And we do a lot with kids. We do hands-on learning for every child at every visit in regards to health. But I have to say that the learning process, and I think it was Ben that said I'd become we're all continual learners. You asked me what I do for a living. I'm a dental student.
Right.
And I think that knowing now that I can really tease out, I had a little boy come to me today from, I don't know how many miles away. They drove 3 hours to get to me, and he was referred by his physician who heard about us. And anyway, he comes in and I look at all of his facial development and he's actually doing well. But obviously there's an obstruction because he's snoring and open mouth breathing and struggling. And he has all the things, all the parent told symptoms. And I just said to the little boy, why are you here? And what are you wanting better out of life? And it turns out he's drinking Red Bull right along with his 16-year-old sibling. And he's drinking that at night with pizza. And he's chronically stuffy. He's allergic, and he's now developed large tonsils and adenoids, and he's got screen time in his room. And I mean, he's trying to be the older kids, the 14 and 16-year-old. And so, working on nasal hygiene, myofunctional therapy, mouth taping, like I'm going to see you in 6 weeks. I'm not throwing oral appliances on. And I want to say it's a privilege to be able to tease out some of those, even just to be able to look at this individual and say, what are all the factors that's impacting this child's life and how can I help? And if if it is a facial development problem, oral the entire facial respiratory complex, I have tools for that too, and that's a privilege. It takes a while, and all I want to say to you as audience members, thank you for being here, and just know that it is the journey, not the destination. All of us are on a journey. All of the panelists. We're all learning, and our best teachers are our patients, and our best solutions come from being in a community of people like this tonight who care so much and are willing to share some of their own toolbox with you. So please just keep learning, keep opening your eyes and your books, and pay attention to the literature. Jump on Google Scholar or PubMed or ask us, and we're happy to share the literature. And just thank you for being here. You're already way above your peers.
Exactly. Thank you so much for that encouragement. And let's welcome Dr. George Rivera. Thank you so much, Dr. Rivera, for joining us tonight. And you were our kind of closer at Airway Palooza last year, and brought a lot of people to tears with your cases. But why don't you give us a quick overview of how you got started and a quick introduction? And then what I'll do is we'll just go right into our case-based discussion, because that brings us up to 7:25, and we'll start with you, and then we'll go to Dr. Jenna and then Dr. Cassie, and then we'll just get reactions from the work you've been up to. But just to preface that, I remember seeing you at an Invisalign course, and you had no idea about airway.
It's a long time ago.
Yeah. So why don't you take us?
There's another young gentleman on the panel here who was also at that Invisalign course. But anyway, going back really briefly, I won't repeat my story, but in verbatim. But in a nutshell, I was just a GP like everybody else, earning a living. I was doing fine, or so I thought I was doing fine. And, burnout is a thing. Burnout's a real thing in dentistry. Our jobs are really hard. And I just kind of, I don't want to say that I did it all, because I feel like I'm just in my new infancy now, learning all this wonderful new stuff. But I just got to a point where it wasn't good enough anymore. No matter how many crowns I did, or how many veneers, how many cosmetic procedures I did, I just kind of got really bored. And, I think it was in meeting Ben and getting me into this this universe. I started doing case, and I think like Susan just said, just keep learning. And I just kept, thanks to Airway Health Solutions, you guys were a big part of it. I think through Kevin, then I met, through Ben, I met Kevin, who, we're really lucky to be neighbors here in Chicago, and he's always been really generous with me. And so, I've never looked back. So the practice is, I don't think I've picked up the handpiece in months. I have an associate now that does that. And I believe she's about to launch her airway career with you guys any minute now. And so I've already started mentoring her. We are absolutely crushed. Ben tried to warn me about this 4 or 5 years ago, and I did not listen. And so I said, sure. And everything he told me came true. We now have to limit the amount of new patients we see daily. These parents are one thing I can tell you. I don't know how it is in other cities, but they're desperate. These parents are just desperate. Nobody will help them or their children. And so, yeah, it's been a wild ride. And next month, in April, I'm going to see Mariana Evans and at Penn, another great mentor and resource. And so, yeah, that was my journey in a nutshell. I kind of went in through the back door. I started my career in general dentistry, and here I am in my second half of my career. And I wish, if I do it all over again, people say, well, what would you do different? I wouldn't change anything. I would just get a time machine and go back and have started with this.
Right.
And maybe that's what we need to do, is change the curriculums in the schools. I know Kevin is really working hard, and Steve is working hard doing that. Amazing work at the ADA and trying to get people to listen. But things are changing. I think we're moving in the right direction. So anyway, I don't want to talk anymore about my story. That's my thing, so yeah, it's crazier now than it was when I was in New Orleans, by a multitude of three. It's almost indescribable.
So do you have a case I'm going to have you do the case presentation?
Yeah, I have a
kick
case.
off
I know
with
we're
that?
talking about, yes, I do. I have a great case. I have one case to show you
Oh,
that,
sure. Wait, Dr. Carstensen just wants to chime in.
Yeah.
Yes. Wait, you're on mute. You're on mute, Steve.
Kevin and I
There
are
we go.
balancing this. So I'm here at the American Equilibration Society meeting, and Dr. Dunning of the Dunning-Kruger effect was lecturing today, and he put this quote up. And George, something you said fits right with this. The quote is, "A person ceases to be a beginner in any given science and becomes a master in that science when they have learned that they are going to be a beginner all of their life." Isn't
Yeah.
that great?
Yeah, that's
So
perfect.
you don't master things
that's
until you
pretty much
realize
the whole
that you're
ballgame. Yep.
beginning every day.
Yeah.
And certainly we have skills. We've all gained skills because of what we learned from everybody on this panel and many others. But this field, these children, we can't be anything but beginners every time we encounter one of those kids. And I think it's a powerful mindset.
Yeah.
So I love that.
Absolutely.
Yeah.
That's wonderful.
Right,
Thanks for sharing.
Do you want to see the case?
Yeah, let's see one of the lives of how many children have you treated, do you think now, George? Can you give a number, a roundabout?
It's hundreds a year. I mean, it's there are some. I can just give you some anecdotally. There are some days where we're seeing 6, 7 new kids a day. We've choked it down to 3 a day because the administrative load is too high. And these are new kids coming in. I don't know, hundreds. I don't really count numbers. I've never been a numbers guy. We just keep coming in, and we're not advertising these are the parents finding us. And I think Ben can attest to this. Many come in out of state now, which tells me it isn't so much that I'm doing great things. It's more like we need more people.
That's what we want to do tonight.
That's I think that's really, and what I really want to talk about today is collaboration, because that's this one case I think we'll speak about to, like Steve and Kevin's points of what does Kevin say, fix by 6? Boy, I'm going to show you a case now that they missed this kid. And so it's a high school kid. And in this one case, I think represents everything that's wrong with traditional techniques and also how we fixed it. And I think how we turned this young life around. But I had a lot of help. I had a lot of help from myofunctional therapists. I hope she's here today, Hannah and Dr. Gabelis, but I want to show it to you. I'm really excited to share it.
Great.
So
let's see it. Go ahead.
All
Share
right.
your
So how do we do this? Are we there?
screen. Just gonna share your screen, that little green arrow.
Yep. Let me get to that. Share screen. Okay, here we go. And I'm gonna do the whole thing here. Okay.
I don't know if it's sharing yet,
Hold
though.
on. There we go. So let me go back to the start of this. And I'm going to blast through this and get through quickly so that we can get to some questions. Okay. All right. So this is a 15-year-old Melissa. This is she's been my patient since she was in middle school. But this, to your point, Lauren, this was my you still hearing me here? You guys still got me?
Yeah.
Okay. So to your point, what was I doing before I became this airway neophyte? Well, this is, a patient like this would come in my practice and this looks perfectly fine to me, or used to anyway. Of course, you guys are looking at this now and picking it apart, but this was a 15-year-old. This is somebody else's ending, and this is my beginning. So she's 15 in this photo. This is after 3.5 years of fixed ortho. Okay, and there's some of my original jotted notes from my consultation. So she returns in 2017 after 3.5 years of fixed ortho, and these are her symptoms: poor sleep quality, headaches, jaw pain, and according to her mother, living on ibuprofen 24/7 to manage her pain. So we take a look. She comes back after a little bit of consultation with the family. And what do you do as a general dentist? Well, you place an occlusal guard. Jerry Simmons is probably screaming at the screen right now because we know this doesn't really do anything to treat the cause. But this is, again, way back 2017, did the best we could. She did not get better. In fact, she got worse. So this is my actual copy of the referral slip to the oral surgeon. I said, blank, please evaluate for TMJ internal defects. Melissa is having pain associated with their left TMJ. Wearing guard, will be following with insert orthodontist name there. Regarding occlusion and options for refinement to improve occlusion, thanks, George. So I knew enough to call the orthodontist, and you could probably guess what happened. I called the orthodontist, and he said, everything's fine. This isn't due to her occlusion, so on and so forth. So I think at the time I'd reached out to Ben, and I said, Ben, I've done a consultation with your orthodontist. I remember these words, Ben, as if it was yesterday. You took one look at the case and said, yeah, that's not her best bite. So we proceeded. She had to go to the oral surgeon because her pain got so bad. And she had arthrocentesis in the left TMJ. She comes back a week later, her pain is gone. Okay, so I was feeling pretty good. I was like, okay, well, maybe this will be easier than I thought. But not so fast. In November of 2017, a little time goes by. Now she starts having the same symptoms in her right TMJ. Left and right auscultation, normal. Max opening, a little restricted, 32. Her mandible deviates to the left on opening. She's got pain in her left TMJ now, the one that was surgically treated with the arthrocentesis. Now she's got pain when she goes to her right excursion. Her left temporalis is firing. Now she's sore, and all her pterygoids are on fire. So she's not getting better despite these interventions. Interestingly, I find that she's got a premature contact on CO, and she slides forward to CRO. So something's not right here, right? And she's going into this really bad acquired occlusion. Now at this point, the family's so desperate, they start physical therapy, not myofunctional therapy, physical therapy once a week. And there's the CRO contact. So I take my records now. And if you notice something, I was just shocked when I looked at these photos earlier today. I had forgotten this case, how much she's 17 in this photo. And look how much she's aged and deteriorated in 2 years. So you see these teeth are relatively straight, a little bit of relapse here from not wearing a retainer. You can't blame her, she's in pain. Who would want her to wear the retainer? But I took a look at this, and you can see here that the mandible's deviating to the right. She's got the tired venous pooling, just a lot of things going on there. This was invisible to me 10 years ago. And so, but this was what the fixed arch wire technique did. And as I said, she's now 17. So here's a close-up for everybody to take a look at the case. This is the arch finish. And you can see all what's going on here. Everything's inclined in. You see the limited oral cavity volume. Spoiler alert, there's a little bit of a tie here. Of course, I couldn't see that back then. All right, so how did we correct this? And I wasn't even doing expansion back then. I was doing expand procline with aligners quite heavily. So this is just kind of a little loop of what we did. It's crazy to me when I see this, how little I really did here. Okay, how little I did and the effect you'll see in a minute it had on her. So there's the U-shaped beautiful dome. There's the narrow, and you can see that she had premature contacts when she had that V in proper shape. So we just gave her that anterior and nice U-shaped arch. And here she was before we started. And here she was after about 8-9 months of aligners. Now, if I had to do this case today, I would definitely be doing expanders and then going in with clear aligners. But this was the best tool I had at the time. And so this is what I did. Got her a little more room for her tongue. There's the lower. You can see the relapse here because the muscles haven't been worked. There's another spoiler. No myofunctional therapy, just straight expand procline aligners. Okay, and there's the finished case. All right, so I'm feeling pretty good about things. She's feeling great. Sending her off to college. She's now a senior. She's off to college. She goes to college for 4 years. She comes back. Okay, and this was again just for comparison, the before and after. You could see how the mandibles kind of straightened out nicely without surgery. She was no longer shifting. But here's the problem. She gets worse. She goes off, and this is why I love this case as a teaching case. She gets worse. Now she's really struggling with breathing. This is a quick snippet of a consultation with the ENT. And you can see I've highlighted here, she had sinus congestion on her intake, nasal congestion, ear infections as a child, loud breathing, snoring. Okay, there's a clue. Facial pain. And here's a big one. Huge tonsils as a child. So everybody missed this, right? The pediatricians missed it. Early intervention did not work for her. Everybody kind of let her down. So now a little jumping around here, cutting to the future. Here's the CBCT I took before I sent her to Milt-Gavelis. Not a bad airway, 161. Of course, that's standing up, probably collapsing when she's sleeping. Okay, so now it's 2023, and I am a big fan of myofunctional therapists and a big fan of the release. So this is thanks to Dr. Gavelis, did an amazing job with this case. Hannah Cassidy at Simply Communication, I work with her quite a bit. Just did an amazing job with her. Her sleep quality improved just with Hannah's intervention a little bit, just starting to help with her breathing and starting to help with her function. But here she is trying to get tipped to the spot before. This is actually the day of surgery at Dr. Gavelis' office. You can see the deformation of the tongue. And now this is 6 weeks post-op. Little scar tissue there. Just beautiful release. And then here is, I love this picture even more. Here she is attempting to do her cave. And look at the difference, what Hannah was able to do here. Now, this is before release. She's producing her cave, but she's compensating. And then this is 6 weeks later. So she's got full elevation. She's up in the anterior. She's up in the middle. And you can see that she's not compensating anymore. Okay. So about a month after that, I got an email from the mom. And the mom sent me this email. And I just about fell off my chair. I literally was rubbing my eyes. I couldn't believe it. Remember that I finished this case in 2017 and she went off to college. She got worse. And so I looked at this. I said, how could this be? So here's her picture after I finished her. So I said, well, why don't you come on in? Sounds like you're doing great. Let me take your picture. And this is walked in my door. So this is her right before I started her second round in ortho, the first time with me with the liners. And this is her photo just February of 24. And this is why I love this case, because it wasn't too late for her. Now, she suffered terribly, but we were able to achieve this with the correct technique. So what did I learn? Well, I will not start a case without having the myofunctional therapist evaluate them right away. They're seeing me first. And I mean, they're leaving our office with their card. And I'm saying, go get an assessment. And then, I don't decide when the release happens. I trust we have wonderful miles here in Illinois. And as I'm sure you do in your states, but I let them decide when the release happens, when they're ready. And then I work exclusively with Dr. Gavelis here. I'm very lucky to have him as a mentor and a friend. He's 20 minutes away. I was on the phone with him today, and I talk to him every week. And to me, the heroes of this case, I did a little bit. I did help her. And I'm glad we were able to rescue her from that prison of pain she was in. But really, the reason I wanted to share this case, and I know the focus is on early intervention with children, is to get everybody to think about collaborating this way, because that's how I was able to help this person. And if you can help one person, you can help the next one. And so just interestingly, this is kind of funny. Here's Hannah, an email. I hope she won't mind sharing this, but the mom sent me this email and said, hey, I just thought you'd enjoy this update. This was more recent in September 24. She said, Melissa came home hanging with her dad and her brother, and she commented how she was scoring over and over when shooting hoops with her brother. She felt like our form, etc., was better. And look at this last line. We both thought that it was probably because of her tongue tie release. Okay, so the word got out, and people listened, and we were able to do this. And so I show this case to a lot of parents now of young kids, whether they're 3 or 4 or 5, as a cautionary tale of what can happen if these things are missed. And I was part of the problem, to be honest with you, because she's been my patient since she was like 12 years old. So I missed it too. So when you speak, when Susan spoke about keep learning, keep moving forward, I never know when I go to these meetings what little tidbit I'm going to pick up that I can bring to help the next patient. So anyway, that's all I got for you. I'm really glad I was able to share this with you guys, and I hope somebody takes something away from it. But I've got other ones in the pipeline that are even more extraordinary than this. And so you can see why I call it my second career. So.
Well, thank you for that. And thank you for sharing, Dr. Carstensen.
No, you're welcome. Thank you.
Just
You're
unmute
muted.
again. Mute.
So George, congratulations on stepping forward and going ahead and taking care of that young woman. But talk a little bit about how you communicate something that you've learned new like that, because you've been taking care of her since she was 12, and now all of a sudden at 17, there's all these things you have to do now. So the parent, maybe not these parents, but other parents are going to go, well, why didn't you tell us about that 5 years ago? Lots of us in practice are going to be facing that conversation. So what's worked for you in that situation?
Yeah, I like a lot of analogies, and when they built the Titanic, the hubris, said, well, we don't need lifeboats because it's unsinkable. Well, now we know that was not really the best of plans. And so what I tell them is that healthcare is a continuum. It's not a straight line of just A to B and you're done. So that we're always learning new things. So I've used the example of let's use like the Jarvik heart. There was a time, a long, long time ago, that they thought it was a great idea that they would take out a human heart and and put a pump in, and you got to live for a year. Now, can you imagine telling a cardiac patient that information today? It's malpractice, right? But well, we're using, the best information we have today. So what I tell parents, and I don't have that problem now, but I do know that I had it. You're right, Steve, that I had that initially when maybe I'm the person that sent them to the orthodontist. Then they come back, and now my hygienist is sitting there saying, hey, you're too narrow. Let's take a look at these lip ties, so on and so forth. And so it's a delicate conversation, but I think you just, I'm trying to remember how I did it. I just kind of took a hard swallow and very just carefully started educating and saying, take a look, show pictures, see how your tongue doesn't go to the roof of the mouth. And what helped a lot is the PSQ, the questionnaire, because I never do a consultation without showing the PSQ back at the parents, because they kind of forget when they're in your office. I do a lot of my Zoom consultations, and I'll say, let's take a look at the form that you filled out when you were here last week. And they see their own words: restless sleep, night sweats, wet bedwetting. And so they start to see that there's a problem. And when you begin to see there's a problem, you're not so worried about the little picayune things like, why didn't you tell me about this before? They're just grateful that you're telling them about it. So I don't have an easy answer other than say I just tell them the truth. I think the truth always, if you're always honest with people, and I just tell them I didn't know back then. I didn't know, and I don't blame the orthodontist, because I think Kevin has always spoken about this. I think he's spot on. It's like we're all doing what we were trained. I went to a good school. We all went to good schools, and I learned what I learned, and I did the best I could from it. I always thought I was doing the best for my patients. I'm sure that 5 years from now, I'll look at how I do these cases today, and I'll probably say, wow, what was I thinking? I should have been doing this, so anyway, it's a great question. Now I rip the Band-Aid off. I don't mess around now. They come in right away. Within 3 minutes, how can I help you? Boom. Because I don't have the luxury of time anymore. I don't know. I guess that's the best way I can explain it.
Thank you. Great question. Any other panelists want to follow up with Dr. Rivera's case?
I'd like to just say one of the things that I say to people is if I could time travel, I would be the dentist I am now with the skills I have now and the insights I have now 20 years ago. Or really, if I could time travel, I would go back and treat my dad as a child and save him from
Yes.
5 strokes in 6 years, right? And died at
I remember the
73.
story about your dad at Airway-Palooza, and it was very moving.
But that time travel idea, they can conceptualize. I wish I knew now what I knew then, or then what I know now. But if I could do it over again, I would go back. And that level of humility that you show, George, when you say, I missed this. I wish I'd seen it sooner.
So
is touching.
Yeah.
It's so genuine.
You talk about time travel. I make a joke with some of my colleagues about, as they're putting the last nail in your coffin, you put your hand up and you go, wait, I think I've got this figured out. Let me do it again. And that's kind of how I feel. It's like, I feel like we're constantly learning and we never really get there. But I think it's in the trying.
Among those panelists, raise your hand if you've been involved in serial extraction in your career. I have. I have ordered those extraction slips. I have created some of the problem that got us to where we are. And that's heartbreaking.
Yeah.
But,
Thank you. I think we're going to shift over to Dr. Schwibner, and she's going to share one of her cases that are, or I think maybe a couple cases, because there were too many, I think, that you had to choose from, right? So we said, let's get some before and afters, and I'm going to give you the floor.
Now I'm looking at George and I'm like, oh, that's how you do one case. Like you explain it so well and go over all that. I'm like, oh, I could have done one case, but My cases are
Excuse
just
me,
kind
real quick, Jenna. I just showed you my good one. Someday we'll talk and I'll show you all my failures.
well,
That's a good
yeah,
course.
I've been humbled as I've started this, putting cases together and sharing things. It really makes you look at how you do things and realize, oh, I missed this image beforehand. I didn't take this photo right. You're trying to put the cases together that you're okay putting on a big screen, and I do think it makes you better. And so that's been really cool for me. But there was a couple cases that I felt could be motivating to show the other people on here, other dentists on here, that it's possible to accomplish a lot with a little. And how can we make a difference? Because it can be very overwhelming when you first start. And sometimes when you feel like you can't do it because you're just not going to do enough, or you don't know everything yet. So what I would say is that even if you take the one course and you start doing guides, you start referring to the myofunctional therapist, you do, refer to the tongue tie. Just if you refer, you're doing more than what they would get from the most offices. And so I love that you talked about collaboration. And so my cases there's not many slides to go over, but I'm just going to show a couple of little things that as a general dentist, I never thought that I'd be able to do because it's so far away from what I was trained in. And the scary thing is we live in a world now that's very litigious. And so it can be really scary to do something as a general dentist, like braces or surgery, tongue tie releases. All of those things can be scary. And I think that's what holds a lot of doctors back. So I think it's important to realize that it can be done. And if you do it with heart and you get the proper training, take it a step at a time. But I always felt like, I think Ben probably remembers I called him crying one night, just saying like, I'm not good enough to do this. I don't know what to do. I'm so scared I'm going to do something wrong. But at the end of the day, I knew that doing something was better than nothing, and I couldn't practice and do nothing. And I'm like, you know what? If someone gets mad at me, I get a bad review, or God forbid someone comes after you litigiously. I'm like, you know what? I'd rather that than have a kid suffer because I was too scared. So I wanted to try to motivate a little bit by showing what I can do. I'm just, a young primary care dentist that can't say no. So let's share this here and tell me how that goes. All right, you guys can see that?
Yep, looking good.
Okay, so let's see. Move my mouse here. All right. So, hold on, my mouse here is kind of funny.
Your keyboard too, if it doesn't work.
There we go. Okay. So what I tell when I'm talking to doctors, I talk about, my main goals are to not extract teeth and have an expansive approach that we focus on remediating symptoms and preventing further development of sleep disorder breathing and hopefully end stage sleep apnea. And the biggest takeaway that I try to tell people is that we look at the why. So it's not enough just to straighten the teeth, but we have to say, why did the teeth get crooked to begin with? And that's addressing tongue placement, muscle dysfunction, and building that proper foundation to protect the airways. And of course, we try to avoid extractions and IPR to accomplish that. So I missed my again. Hold on. like on 3 different screens here because my mouse pad doesn't work well, so I apologize. Oh my goodness, where did it go? Let's try this. Sorry, guys. Technical difficulties.
Well, while you're doing, do you want a moment? I can take a question. Oh, I see the arrow. I see it. Yeah, I see the mouse. You see this?
It's on like
at the bottom.
2 different screens. I don't know how to get over to that screen. I'm sorry. Let me.
Do you want us to come back? And there was a question here that perhaps maybe Dr. Mariah, maybe you can answer this one. It's when it was Dr. Rivera's turn, is as you get wider like that, how do you not get spacing everywhere?
Oh yeah. Well, George approached that first round with the liners. And so the easiest way to envision it is think about, let Jenna go ahead. We'll get the question.
Okay. Okay, go ahead. Sorry.
Okay. Yeah, I hit my mouse. I don't know why it was coming up. Okay. So anyway, so what I feel like is a huge thing we can work towards, right, is trying to avoid the premolar extractions. So if at the very least we keep all the teeth in there, when they're an adult, they're a lot easier to handle, you know, because whenever we get these adults that already had the teeth extracted, we're always like, oh, this is going to be a lot harder. So let's at least try to keep the teeth in. So we get a lot of these orthodontist recommended premolar extractions. And once again, we say, well, why do we have such crowded teeth? Why do we not have enough room for all the teeth to the point where we need extraction? So this is definitely a geriatric patient in the pediatric world. He was 11 years old and he was 28 millimeters across. What we know from Dr. Ben is that 28 is too small at any age, definitely 11. And so he should be close to 40 at this point. And of course, that's why the orthodontist is saying teeth need to be extracted. So we look at the palate.
Dr. Jenna, could you just point out what that transverse measurement is on the photo, where you measure from? Because it's such an important measurement.
Yeah, so we measure from the lingual CJ of 3 to the lingual CJ of 14. And, you know, I try to do it kind of right in the middle here. I don't know, Ben, if that's exact. I feel like when I measure kids, I used to measure them like, oh, you get it here, you get it here. Sometimes it's a little bit of a range, but I try to keep it consistent and kind of do it right in the middle there where that groove is. And so, you know, you can see how small his palate is. And what I tell parents, which I feel like is a really big aha moment for them, is that the palate is the same bone as the floor of the nose. So as that palate is high and vaulted, our nose is being blocked as well. So these poor children have small mouths and small noses, and they're trying to breathe. And it's really a scary situation for them. So we need to remodel that palate and remodel that internal nasal flow so that they can not only have straight teeth, but they can breathe. And parents seem to really understand that. So at the end of the day, they don't want extractions for their kids. So I try to set them up with realistic expectations, even though I have yet to have a kid that ended up needing extractions after we expanded them. I always just say, hey, what's the worst that can happen? You know, you're already looking at having 4 teeth taken out of your child. That, to me, that is unnecessary surgery and trauma to put a child through. You know, it's funny, they don't want to do a tongue tie because they think it's unnecessary surgery, but they're going to extract 4 teeth on a regular. That seems super aggressive to me, and parents are very motivated to say, yeah, let's try it. Let's do everything we can. Worst case, we're losing teeth. We already are there now. So it's usually a pretty easy sell, but when you see a case like this, you're like, oh my God, can I do this? And I think back again to, you know, my first case ever, I think, was same thing. She was going to get extractions, and I called Lauren and Ben, and I said, I'm about to go into this consult, and I got to pretend like I know how to do this. And I know that she needs this, but how do I go against the orthodontist in town that everyone refers to? And they got on a call right with me, and when they had a motivation, I was sitting in the parking lot of Target, And they said, okay, this is what you're going to say, and you're going to save a life. And like, there was like a coach, you know, they patted me on the back and said, you got this. And she has all of her teeth in her head now. And she, didn't have any extractions, and that's great. And I don't even think the parents realized what a big deal that was, because I really undersold it at the time. But so this kiddo anyway, so he didn't have any teeth. You see, there's really no room for his canines at all. And mom said it wasn't highly symptomatic yet. He was mouth breathing and fidgety. But if you look at that profile, I mean, if we take teeth out on this kid, what we're setting him up for not a good future. So he's still in brackets right now. So we're not done yet, but he was just such a cool case that I just wanted to share what you can accomplish in 11 months. So in 11 months, you have a different child. We did 2 expanders because like I showed he was 28 millimeters across, which we just can't accomplish that with one. He was, I believe, 45, maybe 43. It's hard to measure exactly, you know, with the expanders in there, but somewhere between 43 and 45. We probably have a little too much room. I'm okay with closing a little bit of space, as long as I stay above 40 when we're done. But he's going to be a tall kid. So, you know, 40 to 45 is a good place. And I'm not happy unless he has his wisdom teeth too, you know, so let's hope for that. But look at his smile. I mean, who would say this kid has too wide of a smile or has too many teeth? Like he doesn't. And his profile is still not even too forward. I mean, like we could come more forward, but if we went back, that would have been a problem. And, you know, you think about his nose, how that would look compared to his jaw. I mean, he cut his hair, but in 3 months of treatment, and remember he was 28 millimeters. So in 3 months, he still was small. He probably was 35 millimeters at 3 months. His mom said, oh yeah, he stopped mouth breathing. He's not fidgeting as much. And then, you know, a lot of the times the parents come in, they don't put that much on the questionnaire. And then when you get towards the end, they're like, oh, actually, yeah, I thought that was normal. I thought that, you know, I didn't really realize that. And they start paying attention and they say, you know, I have so many kids that go, I can breathe through my nose. And I start asking more questions. So I'm uncovering more. And every time they come in, I go, yeah, the teeth look great, but tell me how you feel. And every visit they come in, my assistants know in the notes, I want all the stuff we got to say about the teeth, but make sure to say every sleep disorder breathing questionnaire, what is better. And so that motivates the parents. Why are they coming to me when I'm not an orthodontist? Well, I got to kind of sell myself every single time they come in that, oh my God, look how much better your kid's breathing and sleeping. And then and the teeth, yeah, those are going to come. So he still has some room to go. We still have to finalize the alignment, but we know that he's a lot better off than he was 11 months ago. So I'm super excited for him. This is probably a case that I would have been really nervous to take on before the support. So this is kind of what he looks like 11 months later. So before and after, cut his hair, but I mean, he looks 3 years older easily. And we haven't even done the tongue tie release in the myo yet, because we're going to do that as soon as that expander comes out. But we know we're making strides in the right direction for this kid. So that was cool. And then, so that was a really major, you know, TM deficiency, transverse discrepancy, really, really big, really obvious. And I loved what George showed, that something really minor can make a difference. And this is Bianca. She was 15, same thing, post ortho. And hey, it's a pretty beautiful result, really nice teeth. But I had treated the other siblings of this mom, of this kid, the other siblings that were more severe, more obvious, and they got better. You know, her younger brother stopped wetting the bed, stopped snoring. Her younger sister's behavior started to improve. So mom said, hey, you know what? Bianca already finished ortho before we moved here, but she's snoring, excessively tired, and she sleeps a lot, and she's still exhausted. Do you think you could help? So she was 35 millimeters across. So that same measurement, but 35. So that's still too small. And she's a tall female, but the biggest thing is look at the face. What is the face telling you? Look at the darkness under her eyes. Look at her profile and how much work she's doing to keep her lips closed. Like she's having to put so much tension to close those lips, and she's just straight teeth. But we ignored the person behind the teeth. So I said, yeah, you know what? We can do some aligners and procliner a little bit. I don't know. I mean, the bite is probably not not as good as it was before, right? She's not maybe biting down all the way there, but we opened her up, and she felt better. We only gave her about 4.5 more millimeters, but her profile got better. And I don't know how much I did and how much the myofunctional therapist did, but the myofunctional therapist, now that I created the room for the tongue, which is how I talk to my patients, I say, we're going to make room for the tongue. And then we need to release that tongue into the new home that we created. And so we do the tongue tie release, and we always do myofunctional therapy before and after, and they make us look good, you know. But what I do know is the snoring did stop, or significantly decrease, and the dark circles significantly decrease even before the release. So we knew that that helped. But then we do the release, we do the myo, and she feels better. So looking at her face, and this was like 8 months later, so she didn't get much older. 8 months, and her profile, I mean, she's gorgeous, but she's not straining at all to close her lips. Her dark circles went away. You know, she brushed her hair, which we appreciated in the after picture, but she's just a little bit more room for the tongue. You can see that little scar tissue from where we did the incision of the tongue tie release, and I apologize, I don't have a picture of the tongue to show you guys, but we just did a little bit. And we got a huge improvement. No more snoring. Really, really feeling good. So we can do a little, we can do a lot, but at the end of the day, even if we just refer to our myofunctional therapist, and the myofunctional therapist will refer to the doctor that can help them, that they've networked with, until you have the tools to do these things yourselves, patients will travel. And I think that's what's impactful. I mean, even if they go to Dr. Baxter in Alabama to do tongue tie release, they come down to see me for the tongue tie release. They go to California to see Dr. Zaggy. Like, there's tongue tie release providers, there's myofunctional therapists that work virtually. And then, you know, to get the orthodontic, same thing, they'll travel. People can get to the sources. So all you have to start with is a desire to help and make a difference, and learn how to look for these patients, and learn how to at least get them referred to a doctor to help while you're learning how to help. And then hopefully you'll turn from a referring doctor to a doing doctor. And I think everyone at Airway Health Solutions has the resources to get you there. So this is my little foundation it's an educational platform that I started. It's in the infancy of it, but Foundation First, Airway and Sleep Education, that I'm kind of launching and using as my speaking platform. It's a resource. Feel free, anyone who wants to use it. I have videos and different things on there. Just because I started something, I was like, I need to talk about this. I made all these videos, and I said, I need to put this somewhere so that I can refer my patients to it, because I'm saying the same thing over and over and over again, and I'm getting a little tired. And so my patients use it, and then they refer, and then I get people from out of state saying, oh, I found your website and I want to come see you. And I'm like, okay, so it grows faster than you have the energy for. I have 3 young kids that are all growing and thriving and breathing. And if that's all I did, I'd be happy. So that's probably my time. I'm not sure where I'm at. I have more cases, but I've tried my time.
Yeah, we'll have you back, Dr. Scribner, because wonderful. I mean, it warms our heart. I know Dr. Ben is smiling like a Cheshire cat over there, like a proud professor, if you would. It's wonderful. There's a question that I do want to address in the audience is, can you share more about the lower fixed expanders you did for Sky? Is it more of uprighting or expansion? I'm confused. Thanks in advance.
Yeah,
Can
so
I help
obviously
with that?
Yeah, please go.
Lauren, Jenna, bring the photo back up of the lower arch.
Sure.
And Lauren, repeat the question.
Sure. I'll repeat it when we have it back up.
Yeah, because I was noticing that. I was going to comment on that beautiful expansion that you did, because I think I saw 28 to 43. Like,
I think it was for Sky, your first one, but
going back.
Yeah, going back. So the question is, can you share more about the lower fixed expanders you did for Sky? Is it more of uprighting or expansion? I'm confused.
All right, so let's do some math. 28 to 43. How many millimeters is that?
A lot.
10 plus, is it what, 15?
Like 15.
Yeah, so 15 millimeters of expansion, and the lower arch, the molars have a little bit of inclination, and now they're just perfectly upright. So there's a lot of people out there who say, oh, lower expanders don't work. All they do is tip the teeth out. No, if you had 15 millimeters of tipping, they would look a whole lot different than what you got there. What you did was growth. The technique we teach is slow, and you get growth. You have dentoalveolar and mandibular growth in that picture. You don't get 15 millimeters by tipping only. If that was tipping only for 15 millimeters, the teeth would be flat, pointing out at the face. It would be ridiculous to look. So yeah, we're not doing tipping only. That is most impressive expansion. You are now a Jedi.
Could I
15 millimeters of growth. Look at those arches. That kid's going to have wisdom teeth come in.
Yes,
the beauty
Kevin.
of this is what you're looking at is an 18 to 20-year-old whose wisdom teeth will come in and fit. The mandible's bigger, the maxilla is bigger. We're not tipping. It is a simple lower Schwartz design, and the technique we teach is to grow that mandible. And then you're going to recruit the tongue afterwards, because the myofunctional therapy, the releases, and getting that tongue to work for you, that contributes to the growth afterwards too. But here, at least you're seeing what 2 sets of expanders can do, and it's not called tipping. That is growth. Beautiful work, both of you, and George too. That's amazing.
Thank you.
Can I just comment something about this case that Jenna did? Jenna, that case I showed about missing all those clues. You saw the health history of that patient of mine that had the sinus, the tonsils as a child, and all the infections. What you just did for this kid is you took this kid and prevented this child from becoming my patient. So that is a quite impressive case. And I'm just amazed at the results you got. But you saved this child, and you shouldn't downplay that, because not only is it an impressive orthodontic result in my book, and I disagree in the other case you did where you said, oh, well, maybe the bite isn't as good as the first. I always tell my patients, what good are your teeth in your casket? I mean, it doesn't matter how perfect the angle classification and everything, but if you're sick, and you can see quite clearly in that second case, if you can go to that next case, that child, the girl with the
now I got it.
If you can go to that one, I mean, look at her face. This is like my case with my patient, that she just looked like a zombie. Literally looks like she needs a blood transfusion. And what is that? 11 months, you said? Difference?
Yeah, I think it was.
Maybe
8. Like it was, not a lot.
And we're dentists, so yes, teeth are important, but who cares about the bite? Look at her physiology. That's the point of this is that. So anyway, I thought both those cases were terrific, and job well done.
Thank
Dr.
you.
Boyd, Dr. Boyd, I know you want to say something.
Yeah, there's a couple of things that I have found. I mean, a kid comes in, upper and lower crowding, no tongue space, right? So they need expansion on top and bottom, and I put both expanders in, and then I go back in the literature, going back 50 years, and there's something called commensurate expansion, depending on a kid's myofunction. Do they chew their vegetables, or do they drink them out of a pouch? So what I have found is, I'm going to kind of limit it to kids under 72 months old, early childhood malocclusion, primary dentition, is that I don't like burdening kids with 2 appliances. And that tends to, it lowers the blood pressure in the parents. Like Ben says, the maxilla is the criminal, the mandible is the victim, and the lower arch, it really isn't, there's no suture down. You can't expand, the lower arch, orthodontists say, and you can't suturely expand in the lower arch. So you tell them, you're right, you can't suturely expand them because there's no damn suture down there. You can upright a warped alveolus, okay, and that is something that will happen as reciprocal action with the upper expansion till it won't. And McNamara, this is in his textbook, is that the lower arch posterior segments will start to upright, okay? And then when it doesn't, that's when you add an expander to the bottom. And he's called it spontaneous class 2 correction, is that the kid will, if the upper arch is way too wide for the lower arch in a class 2 retrognathia mandible, they can translate forward and it fits. And it's a form of myofunctional therapy. You can have them bite on a bite stick, or you can have them bite on a micro brush and hold it there for 5 minutes 2 or 3 times a day and talking like a ventriloquist, okay? And that will begin the whole neuromuscular process until you can get them into a functional appliance. Now, the other thing is, in the primary dentition, and again, I'm not promoting my research, collaborator at Penn, Mariana Evans, but she's a brilliant orthodontist, periodontist. In her class, she's teaching expanding, transverse deficient upper and lower arches before the age of 6 in the primary dentition when there's no crossbite. And when you expand a child in, the upper and lower arch, even if there isn't obvious airway issues, even if there isn't a crossbite, she says to her students, if this, I'm not going to say anything about airway as to why you should expand in the primary dentition, because you wouldn't be here right now if you didn't understand that. I'm going to talk to you about age-related periodontal disease. When you develop those arches in the primary dentition, those unerupted incisors that might still be up in basal bone, not even into the alveolus yet, you are creating a bone. She calls it juicy bone for those teeth to erupt into, such that they will have good support, good mucogingival junction, and they will resist age-related periodontal disease. So don't, I'm glad that people are assessing risk in the primary dentition, but we need more people like Jenna, who's going to develop courage and just start getting in earlier in the primary dentition. So that I think that's really a very important concept to get across tonight here. So thanks for the opportunity for letting me comment on this.
Oh, and thank you so much.
Because of Kevin, I do have expanders on 3-year-olds.
Oh, I know you do, Jenna.
I have quite
I
a bit.
wasn't
I know, I'm
criticizing
just
you.
saying it's don't be scared. And we can make big differences, and at the very least, we can make their nasal breathing better at a younger age. They're going to grow and thrive to be a better human. So I really focus on that improving the nasal volume, helping this kid become an obligate nasal breather at the youngest age possible. And sometimes they need that help of a fixed appliance. Other times, we do imaging, make sure they collaborating with the ENT, doing the guides, whatever we can do, even just recommending a nasal spray, the Xlear nasal spray, that can be a difference, for these patients. So we can really all you have to do is ask the questions and really look at your patients, and don't just, be a cavity bug chaser. There's plenty of those.
There's another factor that I won't bore you with it too much tonight, but I've been boring Steve with it, and he seems interested, but he might just be a good actor. I have discovered something, and it's an awakening. One of the reasons that children, when they're sleeping and breathing better, they do have a better quality of life. And there's lots of articles, they're case reports, and they're not prospective randomized trials. Who gives a damn? It's the best available evidence according to Peter Bouchang and his system. Well, one of the reasons that transverse development of the upper arch in a transverse deficient patient, their quality of life improves, their general health improves, and guess what else improves? Okay, there's evidence now to suggest kids who have impulse control, which is another offshoot of kids sleeping and breathing better, we all know it. Better impulse control before the age of 12, according to the Dunedin study, means that these kids are going to age more slowly. Well, what is rate of aging? Do you really want to start talking about how a kid will age better when they're only 3 or 4 years old? I do. I've become very comfortable with that. Aging begins at birth, actually. And cell divisions can only happen so many times before those cells die out, and they can't do it. That's called senescence. And that's where senility comes from. Senescent cells are present in little kids, and kids who have Down syndrome, guess what? In utero, they have senescent cells, cells that are dying off before they're born, because on the 21st chromosome, trisomy 21, they got 3 versions of genes that code for what? Beta amyloid. Okay, that's 100% before the age of 40 of Down syndrome children will have Alzheimer's disease. Did anybody know that? And if it's happening to kids with Down syndrome, there's things that are happening at a molecular cellular level by us helping these kids sleep and breathe better that are related to cellular senescence, is that they're going to be getting cells that are dying off before they're young adults. Well, the things that we're doing hypothetically, but I'm gathering more data on this, the things you can feel so good, and you already do. Everybody here does. George, I can hear it in your voice. Jenna, my gosh, I just what we're doing, you guys, is going to help these kids have a greater longevity, lifespan, and compressed morbidity, meaning they won't get chronic disease and they're going to look younger than most people their age. And, maybe till they're in their mid 90s, they're going to avoid chronic disease. A lot of them will. So that's just, stay tuned.
Thank you.
senescent. Look up senescent cells and sleep apnea, obesity. That's another thing. We need to be taking body mass indexes on every child that enters you, and promoting healthy eating.
Okay, so can I say comment on that real quick, Kevin? Just a second. That's the micro you just talked about. I remember in your course you talking about health span versus lifespan. That's kind of what you're saying, and the micro level of the senescence. So yeah, helping the health span equal the lifespan.
That's
Yes,
it.
thank you. Dr. Scribner, can you just show the braces part of it? Because there's some questions about why are you using braces? And also, Dr. Moralia, maybe you want to chime in on that, because many people feel that braces are bad. So maybe we can just talk about how you utilize braces.
Yeah, so I think my screen's still up with the braces. Did you want something else?
No, it's not. It's on the it's showing the expander case, the transverse measurement. Oh,
Really?
just go to the next slide.
That?
Yeah. There we go. Okay.
Oh.
Perfect. Yeah. So why don't you tell us about when you use braces and why?
Yeah, so it's kind of a judgment call. And so it's a question, like I'm always back and forth. So I can use all the different tools and accomplish the results, but it's kind of what's going to work best for that patient. So you have to do a little bit of investigation and figure out, for kind of what I've developed, and Ben, you probably know better, but if they have severe crowding to the point like this kiddo that really we need to help get that premolar, that canine's going to be popping through. When it popped in, it was not even close to the alveolus. So I knew I was going to need to help that. Maybe, I don't know, maybe the guides would have gotten it eventually, but I don't have that much patience. So I wanted to really help him along on it. We probably could stop right here and put him in guides and they'd probably finish. To be honest, but once again, like I get nervous, like if they're going to invest in me, I want to control it. And that's probably my control freak side, but the guides can do a lot. And what I found is that guides weren't super successful for me before I started expanding, because you can't guide your way out of more than a couple millimeters, in my opinion, on an older kid at least. And I don't know, Ben does amazing things with it, but it wasn't working in my hands. So I'll use the guides after I have an ideal transverse for that age. And then the guides work really well, but the guides only work if they wear them. When they're in the drawer, they're not super successful. So some kiddos, I think I'm a good cheerleader, but it's hard. So I think if we can get them in with maybe like Tooth Pillow or someone that, that really has that good technique to cheer them on, I think guides can be successful. But this kid just had a lot of room to go, so I do a lot. And that was what my other case I was going to show if we had time, which I don't want to, we're already into Cassie's time, but I do a lot of just expanders and they move into guides all the time. And it depends on their age, really, and how much crowding they're going to have. So if I finish the guides and they don't have significant crowding, the guides are usually going to get us there. And if they're mixed dentition, usually I'm going with guides. So if they're going to be in mixed dentition, by the time I'm done with expansion, I'm thinking guides. But sometimes if you get them at 10, 11 years old, you don't know. So I have to kind of make that call. And this one was a braces one because he was very severely crowded, and I expected to need to do maybe some springs and different things. And that's kind of how I do it. It's not
Dr. Morale, you want to just chime in on that real quick, and then we'll go to Dr. Klein.
Yeah, and also, Jen is using the self-ligating bracket, the carrier brackets with broad arch wires. And so the system that she's using is built to be used after a set of expanders has developed the arches. So she took this kid from 28 to 43 and then added the brackets and wires. So once you have the right size foundation, there is such a thing as a self-ligating bracket. We happen to use the carrier brackets, and we teach that technique combined with broad arch wires. And the arch wires match that width that she developed. So they're massive arch wires. They look like, oh my God, who would I put that in? And meanwhile, it's that kid who has the right size maxilla and mandible. Once you have the right size of the foundation, there's nothing wrong with braces aligning the teeth, because that's what braces are good at, aligning teeth. It just so happens it works a lot better when you have the right size foundation. So right size foundation, align the teeth with broad arch wires, so you're maintaining all of this beautiful shape and form. And then, of course, when the expanders come out, Jen is going to have this kid doing myofunctional therapy and any frenum releases that are needed. So when you combine all of that, yeah, brackets and wires have their place. But in our world, when we teach it, it's only after you have done full foundational development, and you will be including myo plus frenum releases. We don't teach, and we don't recommend ever using braces alone. Braces as a standalone is probably the worst option a child could have. Braces as a standalone only offers straight teeth temporarily. And so the other thing here is this is a child who is going to have 4 bis extracted. So braces as a standalone for this child equals 4 bis extracted plus braces alone. And that's a disaster as an option, considering where this child is now in a whole 11 months later. Meanwhile, we know where we're going with the 4 bis extraction. This kid's in treatment for 3 years with all kinds of retractive forces and a nightmare forever. Gorgeous.
Great.
Just gorgeous.
Thank you. Thank you so much. Wonderful cases. Okay.
I want to say one more thing, just because aligners can be bad too. So it's not the tool, it's the carpenter. So you can do a retractive IPR restrictive non-transverse improvement aligner, and you can do the same thing with braces. So at the end of the day, it needs the right tool, but it really comes with the technician. And so patients say, oh, I already had Invisalign, I already had clear aligners. No, well, you didn't have it the right way. So that's a hard conversation, because I used to be a little IPR, tool, and we really cringe when we see those now. And there's a lot of, you go to these conferences and they talk and they teach you a whole course on how to do IPR. And that's just something, if at least you get that from here, just let's not remove healthy tooth structure, because it's not the tooth structure, it's the jaw. The jaw's under development. Let's not sacrifice the teeth because it's not their fault.
Great point. Okay. Thank you so much. That was wonderful. Dr. Klein, we're looking forward to seeing your case and hearing a little bit more about your journey and where you practice. And you have an airway only practice, and you are a tooth pillow prime practice. So you are the first tooth pillow prime practice, I believe. And tell us a little bit about your journey.
Yeah. So Airway started 2018. Started treating adults, started doing Vivos things, the care appliances and things like that, the guides. Started with my own children, started with, the patients that would listen to me after I've been learning new things, and was so excited to hear me, come back and tell them what I learned at this next lecture that I had just gone to. So, started off slow and carefully, and just got more confident as I went, and just saw such great results, and which was super motivating to have these parents like hug you in the middle of the hallway and just like, oh my gosh, nobody said that to me before. Like, I'm so glad I found you. And then when you get cases like that, you just stay motivated and want to keep going and keep doing and keep educating. And motivates the team, and then that makes the transition that much better inside the practice. So I have been doing the guides, I think, since about 2020 at least. I think I put my daughter in a guide during COVID just for fun.
Okay.
We weren't working. And so I had been doing those for a long time. And then Tooth Pillow came along, and it was such a mirror of what I already do in my practice that it was so easy to want to become a prime provider and offer that Tooth Pillow experience, kind of the virtual platform and the online support and all of that, to my patients that I was seeing every 3 months, just taking photos in my chair. Now we have a whole support team that can keep them motivated and all that. So it was the perfect little marriage. And so I have my virtual patients, I have my prime patients, I have my in-office patients, and I get to help a lot of people and save a lot of lives, which is such a blessing. So yeah.
Absolutely. Okay, well, let's see some of the work you've done, and hundreds and hundreds. I'm gonna say maybe 1,000 children you've saved.
Maybe. All right, well, let me see if I can figure out how to share my screen. All right. Okay, can y'all see that?
Yep, we can.
Let me present here. All right, so this is one of my favorite little cases. He came to me, mom was concerned that he had had a diagnosis of mild sleep apnea, had heard that I did some airway stuff and just kind of wanted to get my opinion on what could be done. She had noticed some snoring, teeth grinding, some speech issues. But I think the thing that we all noticed, mom reported, but we all noticed in the practice too, was some mood swings and some aggression. The consult, we decided we wanted to do upper lower fixed expanders. I always preach nasal hygiene, nasal breathing. We talk about form and we talk about function. There's always two parts to my treatment plans. It has to be both. So we wanted to get him expanded. We wanted to create this nice, good foundation. The day we went to put his expanders in, he said no. He said, I'm not doing that. I'm not putting these in my mouth. You cannot get me to wear that. I'm never going to do this. And I just remember mom was the most patient person I've ever met. And she just talked him through it. And she's like, yes, we're going to do this. And you could just tell she was frustrated, and she knows how to deal with him. This is kind of his normal and how he acts. And so we ended up getting the expanders in his mouth. And I'll show what that looks like when we took them out. But putting these presentations together is super interesting because you get to see the pictures of the teeth, but you don't get to experience the child. And this child became a whole different person. He is respectable, and he is sweet and charming. And I just can't believe that I had a hand in that transformation as a dentist and being able to impact mom's life. Mom's a lot less stressed. Mom's super happy. The whole family is. I'm sure his teachers are and everything too. So you have such an impact as an airway dentist, and it's addicting to be able to do that kind of stuff. So, but this is expander removal day that I always like to take, that I call it the ugly duckling picture. Sometimes the teeth get funny. No fear, we have things to fix that, right? So in my practice, what we do is we do upper lower expanders. We get out to a minimum of 40 millimeters, depending on what we need. And then we put them in a guidance appliance. So like I said, our treatment plans are form and function. So now we've got this form with the expanders. Now we need to hyper focus on the function. And by that, I mean, of course, tongue posture, tongue strength, nasal breathing, all of that, now that we have this big, beautiful foundation, right? So we follow it up with a guidance appliance, one of the big ones. And so this is what he looked like 10 months after wearing a guidance appliance. So brought those teeth in exactly where they're supposed to be. He's got room for his teeth to come in now. And like I said, he's a whole different kid and just a different experience to be around. So I just put these together side by side, and you can see the width that he has developed. It was beautiful. And I was just super pleased with the progress that he made, physically and emotionally. And just in his face and his smile. I mean, so mom says, and she notices, of course, no more aggression. He's got better speech, no sleep issues, performing better in school. So he's just one of those kiddos. This is super close to my heart and a big reason that I do what I do. So yeah.
Thank you. That's
I've
amazing.
got one more case, but I know that
Yep.
we're
No, go ahead. Please do.
on time.
I was hoping you did.
Yeah. So my next kiddo he came to me late, kind of like y'all were saying, kind of geriatric patient, but he had also been told he needed bicuspid extractions. Super narrow. And he's 14, and he was probably one of my first that I was like, can you do expanders on a 14? Like, can we do, almost completely permanent dentition, upper and lower expanders? And this is going to be interesting. But so we went for it, and he was having headaches. He was waking up thirsty. So we're talking about mouth breathing. He had 30 millimeters between his molars, so very, very, very narrow. And we always plan, of course, the nasal hygiene, myofunctional therapy, and then the frenectomies to follow after that. This is expander removal day. We had upper and lower expanders, of course. Big, nice wide arches, still a little bit of crowding. So we set him up. He's going to be in a liner case as well. We're going to do, finish out that expansion, get the bite all settled in and everything. But he did go into a guide immediately after his expanders. And then 7 months in a guide, we have this, which is a much better situation, much more straightforward, predictable airway aligner case than where we started, and no bicuspid extraction, which is a huge win for everyone. So, and I went through that super fast.
Oh, that's great. Okay, well, let's see. Let's see if there's any questions from the panelists, number one, and then I'll look to see if there's any questions in the chat here. Why are you doing frenectomy and myo after and not before expansion, ortho?
So I always I think Jenna said the same thing, is we want to create this big, beautiful home for the tongue and then release the tongue into that new home. It's like creating its own little garage. And sometimes if we do it beforehand, you can't teach the tongue new tricks if it doesn't have any new place to go. So that's kind of how I explain it to my patients.
Any panelist questions?
So for this kiddo, does he have a congenitally missing number 20, or is that premolar, or is that just slow to come in? Yeah.
Yeah, congenitally missing.
I like the question that Carol asked here. It says, I see a lot of vaulted palates on the kids and still seeing it in the after expansion picture. She was kind of expecting the palates would not be as vaulted. And so several of you guys can answer that question.
If you want to bring up the photos again, you could show the upper and lower arches, but most of them show improvement. Most of them show improvement. And so having that change there, you have that wider space, and the next level is getting the tongue in it. So the expanders are going to give you your separation of the two halves of that maxilla. And the next step is the months of the myofunctional therapy coming. So the releases in the therapy, along with the guides, you're keeping the tongue where it belongs, and you keep reshaping that, because we're not done. And even in these age groups, you can still have an improvement in the shape of that maxilla. So we're looking to keep going. This is not the end of treatment. This is just like part one. This is the fixed expander only. Basically, you're looking at one single step in the treatment showing this amazing change, and then go to the other picture of the lower. That's even more dramatic. Look at the change in the space for the tongue. And again, all of, you know who out there with, oh, you can't use a lower expander, it's just tipping the teeth out. No, you're looking at 12 millimeters of expansion. Or no, is it 28 or 30? I forgot the number, but it's a 10. It might be 10, because I know you brought him to 40. Was it 30 or 28?
I think he was a 30. I think the first
he was a 30, right? This child was 30. 30 to 40. You're looking at 10 millimeters of growth in the maxilla and the mandible. And those lower molars are just a little bit inclined, and then they're just perfectly upright. This is not 10 millimeters of just tipping the teeth out. And so we hear about all these myths all the time. And meanwhile, you take a child from totally symptomatic and an absolute nightmare, living as poor a life as they possibly could, and probably either on medication or soon to be. That's where these kids are. And now you give them a position here where the tongue is lost in that space. And now all you need is the myofunctional therapy and then the frenum releases, and you'll have a healthy patient forever. And that premolar over there is considered a permanent tooth now. That will be there for decades. So you have a perfect foundation. I would leave that baby tooth alone. And just like, we've got a few adults out there who have that baby tooth for decades. It's just an implant placeholder, but watch what a beautiful arch development and good breathing and sleeping does. That tooth might be there for decades. What a beautiful case. Look at you. You took a 4x extraction case and you made it an easy aligner case. That's what upper and lower fixed expanders did. Not only did they heal the child, but you took a 4x extraction case and you made an easy aligner case. And I know you well, you're going to do that without attachments, without IPR. Just shape it nicely with some aligners when you're ready. What an opportunity for that child. So you saved a life. Another one saved.
Absolutely.
Love it. I love this case, Cassie, too, or this case and all that you showed, because for the participants, it really shows us that this is not, we're not looking for the orthodontic result of perfection that we normally see from an orthodontist. You take these off and you're like, ooh, that number 7 sticking way out. That's kind of weird. Why did she stop there? You have to remember that we're taking a 2-ton gorilla in a 1-ton cage, that tongue, giving it a bigger home, and now expecting the tongue, as Ben said, the 16 muscles of the tongue and then all the facial muscles to do some of the rest of the work once the aligners are off or once the expanders are off, and then to do the fine tuning, which we don't have to do right away. Remember, we're working on a larger nasal base, a bigger nasal cavity. We're working on a tongue space that will last a lifetime. This isn't about getting perfectly aligned teeth for aesthetics at this point. So, and when you say you can do them really fast, I mean, it's pretty impressive how you can take a kid who's really suffering and in very short order change the trajectory of their life. So I love your cases. Thank you.
Yeah.
Yeah, it's just gorgeous. And look at the tooth changes, even with just the fixed expanders. Like, enjoy that. Don't look at that picture on the right and say, oh, the teeth are still crooked. Shame on that viewpoint. Look at the change in the teeth, because all you've seen here done is Cassie's only done fixed expanders. It's just a fixed expander before and after here. And look at the change in the teeth. Admire the premolar width. Admire that canine width. Look at that width. And then when you look at the anterior view, you can see gorgeous alveolar bone around all of those teeth, because that is not a tooth. Look at that gorgeous mandible. Look at the mandible that you have, the thickness of all that beautiful bone. And in the previous picture where you look at the premolar and canine change, that 10 millimeters of growth that she gave this child, now the tongue has a home. You've got all that gorgeous width, and it wasn't just tipping the teeth up or just moving teeth through the bone. You are looking at growth. That is Jedi level stuff, and you saved another life. It's just gorgeous.
You're a Jedi too.
I love it. I love you all. Thank you.
And we also look at the overbite, how deep it was and how much more volume when she opens the overbite with those appliances as well.
I love to
Gorgeous.
see that.
A couple of key questions. Any issues with root resorption with this level of expansion?
0. I'll just say 0. Absolutely 0. Yeah.
And then also, do you ever incorporate maxillary protraction appliances into your cases?
Very rarely, and I'll say why. There's a very nice amount of research out of Michigan that shows transverse or lateral expansion delivers A, traveling forward, A point, and B point. So when you're doing beautiful expansion, you get your A and B point coming forward. So the transverse development will solve the sagittal problem, provided you go enough, which is why we teach to get these kids to 40 or above. So when you're doing an appropriate amount of expansion, you can then have the enjoyment and obviously the result of A and B point coming forward. So with a transverse expansion technique only, when it's done properly, you can have your sagittal corrected also. But when you only do a little bit of expansion, you are not going to get the travel forward you're looking for. So a few millimeters of expansion really doesn't offer a whole lot and doesn't have much stability either. So we're not a fan of upper only expanders. Those are near useless by all the research. That relapses right back to the start. And we're going off of McNamara, followed by Bogue, followed by Corricini. When you put all of their numbers together for transverse width, getting a child to 40 is the lowest possible number you want to be at. And some of the kids need to be higher. But the good news is lateral or transverse expansion gives you the A and B point travel. So I rarely use protractive headgear. And what Jenna and Cassie will experience as more time goes by, these kids are going to erupt their wisdom teeth, because when you get the full size of the jaw early, you'll have the room for the wisdom teeth more often. So I usually only use the protractive headgear when the child is a full class 3 and they're probably 6 or 7 and above. Because younger ones, I use the guides only, and it flips that bite amazingly. But the 7 and above, probably I would get involved with the expanders plus the protractive headgear because of that class 3 component. But outside of that, no, I don't use it.
I don't know
Ben, if I
why
could,
I've had a ton of these class 3s lately, that even after expanding, they're a skeletal class 3 and we have to do the reverse pull headgear. And I don't know, maybe I'm just unlucky, but I've noticed that some of those super deep bite patients, when you unravel that narrow, you, like we say, that mandible is kind of the victim to that. You're actually more class 3 than you thought. So I'm seeing I expand, and now that mandible drops, and oh my God, they were class 2 and now they're really class 3. So I kind of prepare moms and dads for that ahead of time. I go, hey, we want that lower jaw to grow. This lower jaw might grow fast. And so I look at signs. Like I had one patient, I swear his lower jaw was bending because his baby teeth were down, like his curve was like this. So it was like it was bending into this super deep bite. So he looked like he was class 2 deep bite. As soon as I expanded him and that deep bite unraveled, it jumped forward. And I was like, oh my God, he's in this class 3 now. I freaked out. I called Ben, I called Brent, and I said, oh my God, what do I do? And I said, okay, we put him in a reverse pull headgear for a little bit, and we kind of got him expanded the rest of the way, and he resolved. But I definitely would look out for that more, because sometimes when you develop that mandible really well, you might need to develop that maxilla a little bit with the reverse pull, which I'm doing more of now, but maybe I'm just unlucky. They keep finding me.
so could I please mention
Please.
something?
Please.
Jenna, me too. You can't pull a maxilla too far forward, and Mariana and I both sort of discovered that when we started working together. And when in doubt, most class 2s are also maxillary deficient. McNamara, 1981, Angle Orthodontics. It's real important, and you just can't hurt a kid by putting on a face mask. And here's the other thing, and this is in the literature, there isn't a whole bunch on this, but do it yourself. If you're tracing, and if you don't want to do it yourself, you can send it to beam readers and they will do an airway analysis that I developed for them. And it's called the Linder-Aronson metric. Jenna, you learned about this. And when you measure from the posterior nasal spine to the most anterior portion of foramen magnum called basion, okay, so that PNS basion line, that gets longer because the entire maxilla, the whole, that's why we're seeing a point come forward just with expansion. And McNamara called it loosening up the sutural complex. And if the kid is chewing their vegetables rather than drinking them, if they're doing myo, if you put a face mask on them, you're going to see that distance across the free airway space, even if adenoids don't shrink. And I pointed this out on Becca Bacow and Audrey Yoon's paper, is that you will see in the images that they show where the the adenoids seem to normalize. They said shrink. They got criticized for that. But that line gets bigger, that distance from the foramen magnum to posterior nasal spine gets longer. The entire maxilla is coming forward just with transverse expansion. It's incredible. And I've got a couple papers on it. I'm glad to share them. It was, mentioned as they were looking for something else in an AJODO paper. And they said, oh, that doesn't happen. But oh my gosh, we found out that the basion posterior nasal spine line gets longer. In the free airway space, they don't mention that, but it gets much greater. So that's just another thing. You guys can all be measuring this on your progress cone beams, or even if you're just taking 2-dimensional cephs, you'll be able to measure this. It's incredible.
Yeah. I think there's one question I want to ask, because maybe it could prevent extractions. But It says, I have a patient that has severe crowding and we've had to extract primary teeth. I do not agree with bicuspid extractions for her, but due to her occlusion and limited airway space, she's 11 to 12. Can she still be helped with this type of care? Her upper permanent canines are severely ectopic.
Yes, the answer is yes. Any age, any age. In our advanced course, I show kids 16, 17-year-old female with 2 and 3 teeth blocked out of an arch with the smallest mouths you can ever find, go through 2 rounds of expanders to have the whole entire foundation to line up all the teeth. So there's no need for any extraction on any child at any age. And I'll take it back to the primary teeth. We got to stop taking out the primary teeth because that's not helping with growth and development. That's a subtractive technique. You are shrinking things. The primary teeth coming out too soon allows the permanent teeth that are there to spread out. And it appears like you've made some of those teeth straighter, but there's less room for the teeth coming. So we should not be taking out the primary canines at age 8 to allow the 4 incisors to line up in that space. That is the precursor for the 4 bicuspid extraction technique. So please don't take out the primary teeth. It's not about subtracting the teeth. It's about growing the jaws. So just think about it differently. When you see that you want to take out those primary teeth, instead say, maybe I should make the foundation a little bigger. And then you can keep all those teeth. No premature extracting of the baby teeth and no extracting of permanent teeth ever. Nobody needs that.
Yes, Dr. Jenna.
So I used to get really scared when I get that, like I tell the patient, you need to get expansion, all this. And they say, well, I'm just going to go to the orthodontist down the street because you're not an orthodontist. And I used to get really insulted. Oh, go ahead. And then we get that letter from the orthodontist saying, please extract the baby premolars. And so my front desk, this is a little trick I want to teach everybody. I used to get, my blood pressure used to go up, but my front desk knows, okay, call the mom and say, hey, we got the recommendation from the orthodontist to extract some teeth. Dr. Jen, I'd like to schedule a consult to go over that with you. They think they're coming in for a consult to talk about extracting teeth, because who would extract teeth without doing an exam first? And they come in and I say, hey, by the way, I don't do extractions on children unless there's an abscess. And I really will not do that. I won't extract teeth. I can refer you to someone that will, but would you be willing to listen to some alternatives to that? And I explain the fact that if teeth are being extracted, that the teeth aren't the problem, it's the underdeveloped jaws. And I have techniques that allow us to develop the jaws at this child's age, so that we don't have to extract any teeth. And hopefully we don't have to make that child have to go through unnecessarily trauma and fear, so that they don't like the dentist down the road, and also hopefully prevent them from needing adult teeth that are out. And I have yet to have a mom that says, I want to traumatize my child unnecessarily with extractions. And so that's a really great way to get that parent to sign on to treatment and sign on fast, because we say, guess what? If we do nothing, your child is at risk of those canines turning horizontal and being ectopic and being very, very complex later on. But let's prevent that by developing the jaws now. And they typically say, okay, let's do it. I have yet to send them to an oral surgeon, but I will not be part of that. And I say very fondly, you guys can leave as patients if you want to. You can stay here as patients. But I physically will not remove a tooth from a child unnecessarily. I could not sleep at night. And if the parents hear you say that, usually they don't go for it. So you can save a life with that.
Please pay attention to what Jenna said about complexity. When a 3-year-old comes to you and academically, if they've got a skeletal malocclusion, usually hypoplastic transverse and or sagittal, upper and or lower, usually they're all together, it will, and I don't say worsen anymore, it will become more complex. The longer you wait, it will become more complex and more difficult. So will the child's behavior become more complex. And if there's 2 parents, if they're both on board, then you're a go. That kid is hardwired to want to make them happy. Look at me diving off the diving board. If you get the parents understanding that this is going to improve their child's health span and lifespan, forget it. They're on board. That kid is going to do anything, and they're going to manage the kid's expectations. You won't have to. And that's been through experience. You know, I wasn't taught that in my pediatric behavior guidance training. You know,
Kevin, when I was at Michigan, McNamara was kicked out of the ortho department. He was teaching my anatomy course, right? And in the ortho department, they taught us, because my generation was the first generation with massive amount of crowding and collapse of the face. It was bottle feeding for all of us. It was pacifiers. It was period baby foods, and we were a mess. And what they said was it was because of interracial marriage, that when we started marrying our own kind, this whole situation would get better. We had small jaws and big teeth from interracial marriage. And I had the guts to raise my hand and say, what happened to all the big jaws with small teeth? Why are we only seeing small jaws with big teeth? And they really didn't have great answers, but now we have the answers. And for a child to come in with an extraction slip from an orthodontist, I would simply say orthodontics today really has so much a better understanding. And this is not, and if you all don't have orthodontists that you can refer to that are lending towards zero extraction, you need to cultivate them, because it is not, they're living in the 80s. They're living in the 1980s to do those bicuspid extractions.
McNamara also, in his textbook, Susan, after he, you know, pretty much shows that malocclusion in early childhood, especially at distal step class 2, will always persist. But the reason that we often don't want to treat 3 or 4-year-olds is because that 3 or 4-year-old can't understand the importance of doing the work. And it's like, no kidding. The parents have to understand it. A 3-year-old doesn't have to understand precisely what the rationale is for, and it's literally in his textbook. He says this is really, they're not capable of understanding the importance. So we wait till the early middle mixed dentition. Again, geriatric status.
So I would like to take time just to do some updates and our raffle. And then if the panelists want to stay on for more questions, we maybe stay on an extra 10 minutes because this is a juicy conversation. But I do want to be mindful of their time, and everyone has their 1 CE if they stay to the end. So let me go ahead and just give some of these slides will actually answer your questions. But I do want to we really want more airway dentists. So like, how can we do this? And you guys are so committed and you're here tonight. So we're going to do a flash sale. We're doing $1,000 off our pediatric mini residency. That's to 12 a.m. Eastern time tonight. That's Dr. Ben Moralia's mini residency. Everyone knows we don't do this very often, but it is Children's National Dental Health Month. And we don't think that you can be healthy without a healthy airway. So if you're on the fence and you need a sign, this is your sign, because just like all the panelists said, we need more airway dentists. And we're also going to give 50% off of the Foundations of Pediatric Airway Health course. So we're going to get that in your follow-up email, but we'll give you the links today in the chat as well. And there are the QR codes. So Dr. Ben's courses are the Pediatric Mini Residency, which would be your starter course to get the techniques. There were a lot of technique questions in the chat, and we certainly just can't answer all of them because that's why we created a technique course. So if you want to learn how to do this, the Pediatric Mini Residency will get you going. If you want to learn the advanced techniques like the brackets and wires and the fixed expansion in older adults, then that'll be the course for you. And the Adult Mini Residency is for adult expansion as well as clear aligners. And if you're just airway curious and you want to dabble, this is a good time to take our Pediatric Airway Health Fundamentals. It's not a technique course, but you're going to learn more about the importance of why and see more cases and outcomes. So we encourage you to take advantage of this. We will be, for $500 off our Dental Health Month to the end, will be the advanced courses and the Pediatric Mini Residency for those who aren't live tonight. So this $1,000 off is just for those live dentists this evening. And the $200 off is for the Foundations for all of our electives, which is the Foundations course. The AHS School of Mini Myo is $200 off, and Dr. Maples Looking Beyond the Mouth with Dr. Susan Maples is a wonderful course. And Dr. Boyd's mini residency. I know he doesn't like to brag about his courses, but this is all part of the panelists' coursework as well, to do the early childhood development from 2 to 6, where yes, he will use removable and fixed expanders in this age group. And he teaches you how, and as well as the behavior strategies behind that. So that's something you may want to look into in that age group. And Dr. Maples, let's talk a little bit about your course, because I don't have you on it a lot as a panelist. I just love this course, and you put your heart and soul into it. And I would love to hear it from your words and what people will expect and your goal of creating this course with us.
Well, thanks so much. I'm a total health dentist from infancy to elderly, and this really is all about pediatrics, really through, I would say, commencement through high school years. And we really are talking not just about techniques and in expanding the craniofacial respiratory complex, but really how to identify, how to use communication skills, how to help parents, how to have those conversations, increasing case acceptance, and really building co-referral relationships with the medical community. About half of our patients are referred to us by physicians, and that those come with really, really strong transferable trust. How do you build a community like that? What kinds of community events? How do you market it? How do you, when you hear someone like, Jenna, any of our panelists talk about, I'm so busy. Everyone's like, how do you do that? Part of it is, how do you get the word out in your community? And how do you influence other dentists and physicians to understand this better in a way that doesn't frustrate you or that you don't make enemies? So a lot of those communication pieces, marketing pieces, and business strategies are involved, not just the clinical aspects. Of course, probably half of the day is clinical dentistry.
Wonderful.
Yeah.
It's a wonderful addition. It's a great elective course. So thank you for being on our faculty. And the mini myology, we're actually offering this as a just $200 off as well. So that really focuses on the Fix Under 6 group. It's a great add-on for anybody. If you treat little ones, Brittany does a wonderful job, Brittany Murphy, and take a look at that. We're also launching a new grad program. So for any of you who know new dentists or want to or I guess maybe if you are a new dentist, we are offering only $9.99 for our pediatric or adult mini residency, and only $199 for the foundations course. So just email us if it must be within the past 18 months, and we really just want to see more new airway dentists. So we hope that new grads will take advantage of that program. If you want to learn more about Tooth Pillow, go ahead and scan. It's in our archived conversations. You can hear more about Tooth Pillow, and Dr. Cassie Klein, she is a prime provider. So that's interesting to hear from her and exactly what that means and entails. And if you want to get involved with Tooth Pillow, I know a lot of you have filled out applications and we have them. We are just moving on it. So we're doing this in stages. So we do want to collect the information. We will need a lot more people involved. So please feel free to fill out the application, and we will be getting back to you. We promise. That's for the doctors. And then this is for the allied healthcare professionals to be screening providers as well. So we just have our first cohort released from the screening providers, our MIO providers, and we're monitoring that, and we welcome more in the future. I also want to let you know some upcoming events. There's a free IAOM free webinar that's happening tomorrow night. So take advantage of that if you're curious about MIO at any profession. It's great to add. You'll learn a lot, and it'll be a lot of fun. I think it's a fun interactive session that Joy Lance is collaborating. So that's a free event. And then also the SEC event is coming on, the Sleep Education Consortium in Houston. We're a proud sponsor of that. That's April 3rd through the 5th. They have a stellar lineup. I mean, they have Audrey Yoon, they have Stanley Liu, they have Kevin Boyd's going to be there, Steve Carsonson, a lot of people. It's a great, if you want to learn more and talk to people in person, this is a great event for you. So take advantage. We have a lot of codes that will follow up in our follow-up email. And then we're finally announcing our Airway Palooza lineup. So they were really excited about this. It's going to be a 2-day, and we're going to be starting. Our theme is the airway flow, and we're going to go downstream to upstream. Downstream, we're going to be trying to then cure and treat the disease, and then pediatrics upstream. The next day, we're going to be preventing the diseases. So we're thrilled that we have Dr. Kushida as our keynote speaker, and we're thrilled to have our chairs and all of our speakers, our keynote speakers. So come join us. It's October 17th and 18th. And a lot of the socials are included. It's all under one roof. So reach out for us. And this is going to be the steepest discount, this $500 until we announce this next week. So we're giving one more chance for the early bird special of $500 off. So if you're interested, again, now would be the time for that. And I'm on the board member of the Children's Airway First Foundation, along with Dr. Kevin Boyd. Dr. Steve Carstensen was just at their board meeting with us. Dr. Susan Maples is on the board. They do a wonderful job, and they have a lot of resources for you. So please feel free to utilize that. It doesn't cost you anything. So go ahead and check them out. And I'm not sure if everyone knows about the ADA, this brochure. It's very helpful. I think everyone should order it and actually take this to their pediatrician and perhaps set up a lunch and learn and go over it with them, or use some of our archived videos with the experts, even tonight's, to show how important healthy airways are in children at an early age. So I wasn't aware if everyone was aware of this. And Steve, you want to talk on that a little bit, on this brochure? And are they doing anything new? I know they have the nutrition one, but any updates on the children's airway brochures?
Not an update right now, but the last time I checked with him, and I'll have to verify because I wasn't sure, I didn't know you were going to show this, but if you use the code SLEEP10 when you order this from ADA, you should get 10% off.
Okay.
It's a permanent
And then
code, SLEEP10.
After I do the raffle, maybe we could just, if you have the
turn it back
CGASP
up.
for anyone interested, if you want to get involved and help, there's a way to do that as well. I just want to give a shout out to Mad Rose Media, because they help us a lot with our events. And if you're interested in learning more about marketing your airway practice, they're a great resource, and they will give you a free lunch. So maybe take advantage of that offer too, and get to know them, Peter Beckwith and Greg Hyman over there. They're great to work with. So I think it's time for our raffle. I'm going to go ahead and stop my share and let Jay then, and whoever wins this will win a free Airway Health Fundamentals course. So it's valued at $7.99. So let's go ahead, spin the wheel, and see who the lucky winner is. Okay, Judy Page, Judith, I'm so happy. We went to the AOMT together. So I'm happy that you won this. You're going to really enjoy this course. So congratulations. We're thrilled to have that. And let's just close out. I'm so appreciative of all of the panelists. I'm so appreciative of all of the thoughtful questions tonight. We couldn't possibly answer all of them. And the 280 people who participated live, and the 300 other people who signed up to watch later. We really value everyone, and it's really thrilling just to see the growth of the students here who started as students, and now you're like superstars, speakers on the pulpit, changing the world, the next generation. So what a thrill that was, just to showcase your work. And I hope that was motivating for everybody, because the bottom line is we need more airway dentists, and we do feature you on our airway dentist locator once you do take the mini residency course, and you will get more patients. It happens. We do send them your way. I would love for maybe Dr. Carson said, why don't you close this out? Because first of all, you're in the center. You're like Alice on the Brady Bunch from my screen, but also you're like the diplomat here, and you're kind of new to seeing all of this kind of at the same time with our students and our faculty. So I love your perspective.
Well, the energy that is showing, tonight, and the questions. I mean, what were there, Lauren? 70 questions that came in. I mean, it's amazing the engagement, and that is from people that are listening to this. And so, I heard the passion and commitment that I'm familiar with Kevin and Ben, because I've known them a long time. But to see Jenna and Cassie's and George's, just saying, look, this took over my life because I can't not do this wonderful thing for all my patients. And what a wonder, there's a lot of pulls on our time, a lot of pulls on our energy. But when we are able to say yes to these parents that say, you got to do something to help my kid, and then the kids get better, and then the parents come back and say, look what's happening in our family life. It's not just the child, it's the family's life. And that impact, that ability to take what you learn and turn it into family improvement, and that's community improvement, and that's school, that's classroom. I mean, it's the whole thing. What a power we have, and it's fun for you guys. So I'm so excited to sit and offer my thoughts and watch you guys be so successful. It's just amazing to me, and I'm grateful for the opportunity to be part of this.
Well, thank you so much. And thank you all. Thank you, panelists. Thank you, special guests. We really appreciate everybody. And then we'll see you again, because again, as you keep showing up, we'll keep showing up. So have a wonderful night, everyone. And we'll see you soon. Take care.